In this lecture, we'll cover the autonomic nervous system. In the first part, we'll just make some broad distinctions between the sympathetic and parasympathetic branches in terms of the location of their pre- and postganglionic neurons and the neurotransmitters that they release. In the second part, we'll go through some specific examples of how the sympathetic and parasympathetic divisions act on specific tissues. We'll go through the heart, digestive tract, and then the genitourinary system. This first part, though, is sort of about broad strokes, though, in terms of separating the sympathetic and parasympathetic divisions. So where are they? What do they release? And what are their general effects? We'll start off with the sympathetic division. Now remember that we've got our sandwich. That's how I like to think of this. The sympathetic preganglionic neurons live in the thoracic and upper lumbar regions. So this is our preganglionic sympathetic neurons. All preganglionic neurons are within the brain or spinal cord. In this case, spinal cord. So all preganglionic are in the central nervous system. The postganglionic neurons, for the most part, live nearby in the paravertebral ganglia. And then a few others are scattered around the body on blood vessels, such as the celiac or mesenteric ganglia. There's two of these, superior and inferior. And there's a pelvic ganglion as well. So these ganglia outside the central nervous system, those are the postganglionic neurons. The preganglionic neurons all release acetylcholine. Some of them synapse locally. The postganglionic neurons, nearly all of them release norepinephrine. The exception would be the neurons that innervate the sweat glands. Those still release acetylcholine. But all the others release norepinephrine onto some target. The example that I'll put up here is the heart. Of course, drawn anatomically correct there. The postganglionic fibers stimulate the heart. They increase heart rate, increase the contraction of the heart. In general, what the sympathetic nervous system does is prime the body for action. Rather than energy storage, it's all about energy expenditure. Let's move the blood away from the gut, put it into the muscles, dilate the airways, dilate the pupils. So let's bring in air, bring in light, increase heart rate, and promote a little sweating. All of that deals with activity, either spending the energy or regulating body temperature. The parasympathetic division is found in the brain stem and the sacral spinal cord. Parasympathetic, and so that's why it's the sandwich. From the brain stem, there's a few cranial nerves. So cranial nerve 3, it's the eyes, that's what that is. Cranial nerve 3 controls the size of the pupil, as well as the thickness of the lens. We'll cover this again in another lecture. 7 and 9 control salivary glands and other wetting glands like the lacrimal glands. So the cranial nerve 7 causes moisturization of the eyes, nose, and mouth. The glossopharyngeal nerve will just salivate the mouth. The big one here would be the 10th cranial nerve, the vagus nerve. It'll act on the heart, but it also acts on a bunch of other structures like the lungs, the GI tract, so from throat to colon. The vagus nerve is the major parasympathetic nerve. The postganglionic neurons live on ganglia either near or within the target tissues. So very short axons here. So the mural ganglia live on the target, such as the heart, and the intramural ganglia are within the target. For example, in the GI tract. We'll see this later. Rather than stimulating the heart, the parasympathetic division inhibits it. It doesn't inhibit everything. For example, it stimulates the GI tract because the function of the parasympathetic division is rest and digest. So move blood back to the gut, stimulate peristalsis and secretions so that we can store energy. We can pull it out of the food and put it back into the body. So sympathetic, energy expenditure; parasympathetic, energy storage. Sympathetic, fight or flight; parasympathetic, rest and digest. The synapses of autonomic neurons onto their targets contain multiple pre- and postsynaptic sites. So these are the neuroeffector junctions, so between the neuron and the target that it's affecting. Those neuroeffector junctions, like the neuromuscular junction, have multiple presynaptic sites. So let's say we've got our target here. This is the thing we are affecting. The axon will form multiple synapses as opposed to just one. And by increasing the number of synapses, we increase the strength. Again, in the peripheral nervous system, we're not voting. That's in the central nervous system. So once we stimulate autonomic output, we want to affect the target organ, and we will, because the neuroeffector junctions make multiple synapses. As you can see in the table over here, the neurotransmitter used is predominantly acetylcholine. This is true for all preganglionic neurons and all neurons within the parasympathetic nervous system. The only difference we have here would be the majority of postganglionic neurons in the sympathetic nervous system. They release norepinephrine. In addition to the motor aspect of the autonomic nervous system, there are also afferents, or sensory fibers, within the viscera. The difference between these and the sensory afferents that innervate our skin, muscles, and joints is they have a very large field that they cover. So it's hard to localize pain. Tummy aches are kind of in this area, as opposed to when you have a cut, you can tell exactly where the cut is. You can feel it. Just outside the cut, not so much. That's not true with visceral pain. Visceral pain is a lot more vague and covers a larger area. Now, there's a few types of visceral pain that we can have. Pure visceral pain is caused by stimulation of sensory afferents within the viscera themselves. So we can localize it's somewhere in my tummy. But we also have referred pain, as you can see here in this color-coded chart. If we have, let's say, a heart attack, well, you don't feel it in your heart so much. You feel it more in the shoulder and maybe radiating down the arm. Why is that? Well, it's because of this. convergence of sensory afferents. So the afferent of the shoulder and the afferents of the heart converge. Even though they're different primary afferents, they might converge at the level of the spinal cord under the same secondary afferent. Alternatively, they can converge in the thalamus on the same tertiary afferents. And the thing that creates the sensation is really that tertiary afferent that goes from the thalamus to the overlying cortex. The cortex is where the magic happens. So where do I feel the pain in my heart? Well, let's see, this is the face, and then we got the hand and the upper limb. So probably about here. Why? Because of convergence. Either it's secondary afferents, or, remember this will cross and head on up to tertiary afferents. And that leads to similar activity in the cortex. So we feel it in the shoulder, not the heart. So that would be what we call referred pain. The last type of pain is viscerosomatic pain. And this is where damage in the viscera leads to stimulation of primary afferents in the skin. So as opposed to convergence on secondary or tertiary afferents in the spinal cord or thalamus, the viscerosomatic pain is where the primary afferents are stimulated by noxious stimuli. A good example of this would be with loss of blood flow. That ischemia can lead to stimulation of nearby pain-sensing nerve fibers. That'd be viscerosomatic pain. So it's convergence really at the primary afferent. Convergence at secondary and tertiary, that would be referred pain. All right, on to some specifics. We'll start with the heart. The heart has pacemaker cells that drive rhythmic contractions. And these pacemaker cells rely on a few different types of ion channels. Of course, the dipole, voltage-gated calcium channels, repolarization, voltage-gated potassium channels. So pretty similar to neurons, except we're using calcium instead of sodium. Once we're in this hyperpolarization here, we return to threshold because of the activity of HCN channels. And those are hyperpolarization, cyclic nucleotide gated cation channels. So the hyperpolarization turns them on, and the degree to which they conduct ions depends on the level of cyclic nucleotides. This brings us to the autonomic innervation. Once we hit threshold, we'll spike. The real question is, how long does it take us to hit threshold? And that depends on conductance through HCN channels. Let's consider adrenergic input. So here's my pacemaker cell. Well, there's two types of receptors to think about. I have my beta adrenergic receptors. These get input from sympathetic neurons, of course, that release norepinephrine. Beta adrenergic receptors are GS coupled. We all know what that means. GS stimulates adenylyl cyclase, which is the enzyme that makes cyclic AMP from ATP. Notice, cyclic, it's a cyclic nucleotide. So, if we increase cyclic AMP levels, the rate of depolarization increases, And as a result, the rate of spiking increases. So that change right there is driven by the sympathetic input. Parasympathetic input, which is of course cholinergic, acts on M2 muscarinic receptors, which are GI coupled. GI inhibits adenylyl cyclase, so we don't get the increase in cyclic AMP, we get a decrease. So the rate of repolarization is slower, and thus the rate of spiking is slower. So heart rate slows as a result. Here we can see the effect of stimulating beta adrenergic receptors with isoprenyl in there. So look, left, normal, right with beta adrenergic stimulation. A faster rate of pacemaking. We also affect the contractility of the cardiac muscle. So the cardiac muscle can contract more strongly with sympathetic input because beta adrenergic receptors stimulate protein kinase A. So cyclic AMP acts on HCN channels. It also stimulates protein kinase A. Like I said, the devil's in the details. In this case, protein kinase A potentiates calcium efflux through reanodine receptors. So heart muscles contract more heavily. As you can see here, the amount of calcium generated in the heart increases if you look at that middle panel there. So the beta adrenergic receptors are acting on multiple sites. Pacemakers, heart muscle, also smooth muscle as well. Now the smooth muscle is a little different. Now you can see here in this cartoon what's going on, but I'll give you a little summary here. The contraction of smooth muscle depends on the phosphorylation state of myosin light chain. So if myosin light chain is not phosphorylated, here's myosin light chain, it's relaxed. It can't interact as well with actin. But whenever we phosphorylate myosin light chain, now it can interact with actin, and so we get contraction. Myosin light chain kinase is the kinase that phosphorylates myosin light chain. It's nice how that works out. Myosin light chain kinase is inhibited by protein kinase A. So GS-coupled receptors, which stimulate protein kinase A, inhibit myosin light chain kinase, so we get relaxation of smooth muscle. Now, not every blood vessel has beta adrenergic receptors. Some have alpha-1, which are GQ-coupled receptors. Well, of course, we remember that GQ causes an increase in calcium, and so calcium-dependent kinases, like CAM kinase 2, activate myosin light chain kinase. So we stimulate smooth muscle, depending on which receptor it is. Now, with the blood vessels that serve the heart, we got the sort of larger arteries on the outside and the finer arterioles that head into the heart muscle. The arteries on the outside have alpha-1 receptors, so they contract a bit. Those that perfuse into the muscle have beta adrenergic receptors, so they open up. The contraction of the outer arteries increases pressure that helps drive blood into the lower resistance arterioles because they've dilated a bit. So sympathetic input increases the rate of pacemaking, increases the contraction of the heart, and increases blood flow to the heart. Parasympathetic input really only acts at the sinoatrial node, so it really only directly affects pacemaking. Indirectly, it affects the rest of the heart by inhibiting sympathetic terminals. And it does it with the same receptor, M2, GI. GI inhibits the neurons there. So there's crosstalk between these two branches. So sympathetic stimulates the heart, parasympathetic inhibits. The opposite is true in the GI tract. Sympathetic input largely derives from the celiac and mesenteric and pelvic ganglia. So those prevertebral ganglia, not the paravertebral ganglia, so not the sympathetic chain. Mostly the ends of the GI tract are innervated. So there's a lot in the esophagus and stomach, some in the intestine, and then it resumes once we get around to the distal colon. So celiac is going to hit more the stomach, mesenteric will hit intestine, pelvic will get the colon. Sympathetic input inhibits peristalsis, slows that down by acting on beta-adrenergic receptors. Same thing here, we're dealing with smooth muscle. Beta-adrenergic receptors increase cyclic AMP, stimulate protein kinase A, inhibit myosin light chain kinase, that favors relaxation of smooth muscle. So now, sympathetic input is inhibitory when we're dealing with the GI tract. Parasympathetic input, on the other hand, is excitatory. The parasympathetic input arises mostly from the vagus. The vagus is going to hit the esophagus on down to the colon. Again, more of the innervation is at the ends. The distal colon is innervated by the pelvic nerve. Everything else, vagus. And what arrives at the GI tract are the preganglionic neurons for our parasympathetic division. So let's get the GI tract up here. Now it doesn't really matter where we're at. The GI tract is basically a tube. That looks really bad. Okay, that's better. That's better. Okay. So the sympathetic input arises from the postganglionic noradrenergic neurons, and these are inhibitory. Parasympathetic, preganglionic arrives, and here they communicate with targets that live within the GI tract, components of the enteric nervous system. So the local neurons living within then go and communicate with smooth muscle, mucosal cells, and they stimulate peristalsis. They act on a combination of M2 and M3 muscarinic receptors. M2, still GI, M3, GQ. Both of these stimulate smooth muscle. So we stimulate peristalsis. Now the targets live in a couple different places. So the GI tract contains its own local nervous system that has at least as many neurons as the spinal cord, if maybe 3 times more. So 200 to 600 million, something like that. Here we have kind of 2 layers of target neurons. So kind of on the outer portion there, that's the myenteric plexus, plays a big role in peristalsis. So the contractions, the movement of food through the GI tract. Below that is the submucosal plexus. Also plays a role in peristalsis as well as secretions. So the postganglionic neurons in the parasympathetic division live within the GI tract. There are other neurons in the enteric nervous system that aren't postganglionic parasympathetic neurons. So the enteric nervous system, the ENS, contains kind of two parts. There's the intrinsic neurons that live there and kind of function independently, and then there's the postganglionic parasympathetic neurons. So it has part of our parasympathetic division and then its own neurons that live locally. So the enteric nervous system can function on its own, but it's also regulated by input from the parasympathetic nervous system. If we remove innervation to the GI tract through damage, it'll still work. There will be a period of time where it doesn't work quite so well, but it figures out how to move food through in a coordinated manner because there's kind of an intrinsic, almost gut-brain, if you will. People call it that. Because the enteric nervous system is connected with itself and it can function independently to stimulate peristalsis and the appropriate secretions. So that ENS serves the GI tract as well as some of the other associated organs, pancreas, liver, gallbladder. So they have their own nervous system. Some that's totally independent and some that gets input from the autonomic nervous system. We'll move on to control of the bladder. So, sympathetic tone here. Sympathetic tone allows for storage of urine. So at baseline, sympathetic nervous system keeps the sphincter, internal sphincter contracted, the bladder relaxed. So the bladder, let's get us a little sphincter here. Here's our urethra. I'm going to draw the male version of this. For females, there's no separate sphincter, but for males, the urethra is longer. So there's two sphincters, smooth and striated. So we have conscious control here. Lower motor neurons in onus nucleus can keep the external striated sphincter clamped down. So we have ultimate say over whether we urinate. Sympathetic input keeps the smooth muscle of the bladder, so the detrusor muscle keeps that relaxed. Beta adrenergic receptors, GS, it's smooth muscle. Different receptors on the smooth sphincter there, so in this case alpha 1, which are GQ. GQ causes contraction of smooth muscle. So at baseline, we're not urinating because we don't want to, so we control the striated sphincter, and sympathetic tone keeps the bladder relaxed and the smooth sphincter contracted. And that's what's going on over here. So that's kind of the baseline state. Over time, we pull fluid out of the blood, the bladder fills up, and we get a little bit of stretch. Now that little bit of stretch there stimulates afferents, so stretch receptors on the bladder. As this thing fills up, the bladder balloons out, and that stimulates stretch receptors. So we get the urge to urinate. There's a few targets of these fibers. Of course, it makes it to the cortex. We know we need to urinate. But importantly, it targets the pontine micturition center. This is an area in the pons that controls micturition or urination. The PMC inhibits sympathetic fibers and excites parasympathetic fibers. So those are out here in the sacral spinal cord. Parasympathetic fibers stimulate the postganglionic neurons there, and they have different receptors. So in this case, M2, M3. So that stimulates contraction of the bladder. But we got to fully get rid of our sympathetic tone there. And that's once we actually consciously decide to urinate. Two things happen. The cortex no longer inhibits the pontine micturition center, so it's off full speed. Let's see what happens. Let's make the decision to urinate here. Alright, so once we decide to urinate, as what's going on in the cartoon there, urine's flowing because we've decided a couple things are happening. We're no longer stimulating our lower motor neurons, so the striated sphincter relaxes. I'll just open up a hole there. The smooth sphincter is also relaxed, parasympathetic tone is lost, and urine is flowing out. Now as urine flows through, it stimulates stretch receptors that provide feedback to our parasympathetic neurons to keep them stimulated. If it's just driven by bladder stretch alone, once we get near the end and our bladder is no longer ballooned up, we won't empty the tank. We need to wait until the flow stops. And that's where the urethral afferents come into play here. So these are stimulated by the flow of urine to make sure we continue to contract the bladder. It's not just enough to deflate the bladder a bit, we want to contract it until there's no more urine flowing out. Once there's no more urine flowing out and no more stretch on the bladder, we of course also consciously decide time is up. We can clamp down on the striated sphincter. Those stretch receptors no longer provide input saying there's an urge to urinate, so the pontine micturition center is not stimulated anymore. So we don't inhibit the sympathetic nervous system. Our smooth sphincter contracts and our bladder relaxes. And that's your micturition reflex. Nearby, we also have autonomic innervation of the genitals. And this has been studied more extensively in males because you can more obviously see the end product. You can see ejaculation there. So sexual circuits have been studied a lot more in males, so we have a better idea there. So we're going to cover it there. Alright, so for urination, sympathetic tone prevents urination. Parasympathetic allows for the completion of urination. So parasympathetic kind of ended the process. For sexual activity, the parasympathetic division seems to start the process. So the way you can remember this is point and shoot, P and S. Parasympathetic, sympathetic. Parasympathetic, it stimulates erection. Sympathetic stimulates emission, and thus ejaculation. So point, shoot. Alright, the parasympathetic innervation stimulates erection by stimulating an increase in blood flow. So we have to cause vasodilation somehow. So vasodilation of the pudendal artery. Alright, we'll get a blood vessel. And maybe it's okay if this one looks a little like a penis, but we'll draw it like a blood vessel. So there's a couple components of the blood vessel. We got smooth muscle and then we have epithelial cells as well. The parasympathetic input acts on the epithelial cells. So the release of acetylcholine acts on muscarinic receptors, in this case M1. Those are of course GQ. This is not on smooth muscle, this is on the epithelial cells. That stimulates the epithelia to release nitric oxide, which causes the smooth muscle to relax. Thus we get vasodilation. So parasympathetic input It doesn't act on the smooth muscle, it acts on the epithelium. The epithelium releases nitric oxide, smooth muscle relaxes, we get an increase in blood flow, and now we're off to the races. So the parasympathetic input drives engorgement. Sympathetic input moves seminal fluids to allow for emission. A couple different targets. So the sympathetic component, well, we still act on the beta adrenergic receptors on the detrusor. We're not trying to urinate here. Right? We're going to move other fluids through. So the plumbing's a little more complex here. So beta adrenergic receptors on the detrusor prevent contraction. We also, of course, still have our alpha 1 adrenergic receptors on that smooth sphincter. Again, not trying to urinate, and we don't want any backflow. So we're going to close off the access to the bladder, and we're going to relax the bladder. Then we have all the other targets. Vas deferens, seminal vesicles, prostate. These actually move the seminal fluid from the testes into the urethra, and out it goes. So, sympathetic stimulates emission. Part of that, prevent urination, or MICTURITION, same thing, and then increase the movement of seminal fluids. The ejection involves the somatic nervous system. So the emission, stimulated by the sympathetic nervous system, stimulates the pudendal nerve to help drive contraction of the bulbospongiosus muscles. They cause actual ejaculation. So sympathetic also helps drive activation then of the somatic nervous system to allow for ejaculation. Seems like a nice place to finish, but we're not done. Last thing I want to mention here, spinal cord injury and autonomic dysreflexia. Then neurogenic bladder. So, remember, when we have an upper motor neuron injury, we have hyperreflexia. That's exactly what's going on here. So autonomic dysreflexia. When we have damage above T6. Let's not forget our sandwich here. Anywhere T6 and up leaves the nerves that innervate the GI tract, so that form the splanchnic nerve. These cause vasoconstriction at the GI tract. So this moves a whole lot of blood out of the gut and into the rest of the body. As a result, it increases blood pressure. So consider this an upper motor neuron type lesion. So now the sympathetic neurons that are still intact here in the lower thoracic spine, they're still able to stimulate vasoconstriction in the GI tract, and they will do so more readily. Because they've lost descending input, they'll listen to the other sources of input, which could be pain. Remember, pain stimulates a sympathetic response. Part of that has to do with going up to the hypothalamus, but there are also local offshoots. So when we have a full bladder, well, that's going to stimulate these neurons within the thoracic spine to cause a sympathetic response. It's just a far more pronounced sympathetic response. So we get a much greater increase in blood pressure than we would get normally because of that hyperreflexia. Same thing is true for the bladder. The bladder is also going to become a little hyperreflexic. Remember, we got a reflex built in. A little bit of stretch helps drive a little bit of contraction. Sure, it's regulated by upper circuits, but there are local afferents that create a reflex. So depending on where we have the damage, that determines how does the bladder respond. Because where we have the damage determines, is it an upper motor neuron or a lower motor neuron type lesion. In this case, we're concerned more with the parasympathetic input. So anything above our S2, S4, that'll create spastic bladder. Because it creates an upper motor neuron type injury. So these lower motor neurons here, you can think of them that way, right? Of course, that act on local neurons that control the bladder. These are now deprived of descending input, so they listen more so to the sensory input. So, spastic bladder, whenever we have these higher injuries, so most spinal cord injuries cause spastic bladder, where just a little bit of filling causes contraction. This is often co-contraction of the bladder and the internal sphincter, because the activity of our sympathetic and parasympathetic divisions are not regulated. They can't talk to each other well, and the descending input from the pons is lost. So the pontine micturition center is very important because it acts as a switch. It turns off the sympathetic and turns on the sympathetic when it's active. It makes sure they're not both trying to communicate to their target, because they do different things. The sympathetic input clamps down on the smooth sphincter. The parasympathetic input causes contraction of the bladder. When these co-occur, you get painful contractions with a little bit of urine leakage. So, spastic bladder. At the level of S2, S4, think of this as lower motor neuron type weakness. Now we can't stimulate contraction of the bladder. So you get a flaccid, kind of acontractile bladder that just fills and fills and fills until it overflows. Upper motor neuron, hyperreflexia. In this case, anything above that S2, S4. Lower motor neuron, hyporeflexia. Even though the bladder fills up, we can't stimulate that reflex, the reflexive emptying of the bladder. All right, that's enough for now. If you have any questions on this, let me know, and we'll talk about them in class. I'll see you later.